couple of things to go through, technical stuff. Our host is named Diana Mayfield, and she's listed as CSH event in the participant panel and host in the chat panel. During this session, everyone is muted to reduce background noise. That doesn't mean you can't ask questions, though. It just means that you must type in your questions via the chat box in the right panel. If you're having trouble hearing us, you have two options. Option one is you can log off and restart the event. Option two is chat to the host, CSH event, and Diana will try to help you. As soon as the recording is available, we will send you the slides, a link to the recording, and answers to questions that we weren't able to get to today. So Diana, please press record, and I'll get started right now. Okay, so thank you for joining us today. You've joined CSH's HRSA-sponsored webinar called Who Are Frequent Users? A Closer Look at Definitions Used by Communities. CSH is a national nonprofit. At CSH, it is our mission to advance housing solutions that deliver the three powerful outcomes you see here: improving the lives of vulnerable people, maximizing public resources, building strong, healthy communities across the country. CSH has been a national technical assistance provider for HUD for many years, and now we are also a technical assistance provider for the Health Services and Resources Administration, or HRSA, under Federal Department of Health and Human Services. Our HRSA Technical Assistance Program includes this webinar series, direct TA to health centers and supportive housing providers, setting up regional training, peer learning, as well as creation of resources for the health center and supportive housing communities. Our specific target is to help build health center and housing partnerships that can address the needs of those in our communities with limited access to primary and other health services, and who frequently use the emergency and crisis care system. We partner in our work with the National Healthcare for the Homeless Council. Today we have a great team of panelists. I am the first person that you're hearing, so that's me, Kim Keaton. I'm a senior program manager at CSH, and I'm located in Kansas City. Next, we'll hear from Lauren Berner, who's a project manager, the HRSA TA project manager at the National Healthcare for the Homeless Council, and she's in Nashville. Jill Lubin, who is a program director with JWCH Institute in Los Angeles, and Amanda Pollack and Holly Garvey are both with the high-end utilizer program at Mercy Medical Center in Springfield, Massachusetts. Today's topic will start with defining and describing frequent users, which I will talk about. Lauren will follow up with talking about a specific program, the Tencessl Project in Los Angeles. And then we'll hear from our guest, Jill, who does work with that Tencessl Project, and then Amanda and Holly, who work on a similar initiative in Springfield. So to set the tone and frame our discussion, I'm going to be discussing who are frequent users and what do they look like. Frequent users are those people with deep unmet needs who are caught in an institutional circuit as they cycle between systems. They're often not in one system long enough for outreach workers or programs to reach them and treat them with effective services. Typically, they'll slip between the cracks of traditional outreach approaches by health centers, and they also go uncounted in community homeless counts due to their institutionalization. These individuals very often have serious physical and health and behavioral health needs that would benefit from a connection to the primary and behavioral health care available from health centers nationwide. This frequent system use translates into extremely high costs. This graph shows the system use of the top 10% of homeless individuals in Los Angeles, and the piling up of the costs as the folks go from one system to another and back again. That bar on the right shows how those system costs can really, really accumulate. So everybody has by now heard that housing is a social determinant of health. Well, housing instability then is a contributor to frequent and inappropriate use of emergency health care. On the flip side, several studies have found that supportive housing improves health outcomes and reduces emergency health care utilization and other system utilization. Many programs nationwide have attempted to address this system use, often from the perspective of overutilization of hospital services, though those that overuse hospital emergency services are likely to be frequent users of other systems as well. Some programs, usually high utilizer initiatives, originate out of hospitals, seek to coordinate care for their high utilizers or with frequent users by employing case managers to help homeless high utilizers post-discharge, often connecting them with housing to help stabilize them and reduce readmissions to the health system. Other programs originate in the homeless system and seek to put high-cost utilizers of crisis health care into supportive housing, affordable housing with wraparound support services. Often these programs partner with FQHCs or other health centers to help connect frequent users with health care in the community. We will hear from two examples of these types of programs later in the webinar. Defining frequent users can be very dependent on your community's definition of the problem and who's around the proverbial table when figuring out how to target folks. Some initiatives focus on conditions, while others focus on system use, and still others focus on high cost or some combination of two of these or all three. All three are critical measures in refining definitions will help to understand a target population. In terms of system use, obviously data from the system should be matched and used to determine true cross-system use over a specified time period. The time period should be recent to reflect recent issues. When looking at the data, some natural pattern, especially hospital data, some natural patterns or breaks will emerge, such as the top number of people with threshold criteria of ER visits or inpatient admissions over a given time period, like a year, so something like 5 or more ER visits or 2 or more inpatient admissions over the course of a year, or top number of percent of people who together cost the system some outrageous sum per year, or on average are a big number per year, cost a big amount per year. An example would be if the hospital system spent total $100 million in a year, but the top 5% of people took up, $50 million of those dollars, that would be a pattern that you might want to look for. Finally, resources in your community may drive conditions you consider for eligibility in the program. So targeting just based on system use and cost will inherently capture a frequently using population that has high rates of mental illness and substance use, as we'll learn about in the next couple of slides. But if your funding streams are specifically for those with mental health diagnoses, then you might add that, or a disabling condition more broadly to the eligibility criteria. So after we've discussed system use already, let's get to discussing some health conditions that are prevalent for frequent users. A recent study found that frequent users or super utilizers of Medicaid were more likely to be admitted for medical versus surgical or other types of conditions and had mental health and substance use disorders among their top 10 diagnoses. As you see here, the most common chronic conditions of this group are congestive heart failure, diabetes, and chronic pulmonary disease. On the acute side, you see septicemia, pneumonia, and UTIs, urinary tract infections, all common disorders among homeless individuals. Mood disorders ranked as the most common hospitalization reason for Medicaid superutilizers in this study. demonstrating not only how prevalent mental health issues are amongst frequent users, but also how they drive up costs, since psychiatric inpatient hospitalizations are extremely expensive. So who are the frequent users? No discussion of this population would be complete without actually seeing who they are and what they look like. And they're people just like you and I. These are individuals from the program that we'll be hearing about in Los Angeles. A baseline profile from that program has shown that they have the chronic health conditions that we just heard about from the national study. So hypertension, congestive heart failure, diabetes, in addition to liver disease, which is a result of alcoholism, and chronic pulmonary disease. The majority are male, but the breakout from male to female actually pretty much mirrors the homeless population. 29% of them have jail or probation, so there is that element of even though folks are being targeted from the hospital, there's other system use being shown. On average, the individuals had 18 emergency room visits in the 2 years before referral into the program. They had 7 hospital admissions and 31 hospital inpatient stays per person. The 92% of folks actually have a chronic physical disability. 78% of folks had a mental health disorder. And 71%, 62% of folks have a substance use disorder. 74% had a co-occurring disorder, so 2 of these, medical or behavioral or substance use, and 45% of the population have all 3 disorders. So starting with a national study of this population and ending with a sort of local results, you really see these conditions bearing out as the actual profile of frequent users of crisis health services. Now I'm going to turn it over to Lauren Berner from National Healthcare for the Homeless Council, who just wrote and released a paper on the Tencessl Project in Los Angeles. She's going to be talking about that program. Lauren?
Thanks, Kim. So as Kim mentioned, my name is Lauren Berner. I'm with the National Healthcare for the Homeless Council, but I do work very closely with CSH on this technical assistance program. And I just wanted to give a brief overview of this project because it is a very successful initiative. I'm going to do it at a kind of high level, and we're lucky to have Jill Lubin here today to talk more about the health center experience with this project. So to start out, the Tencessl Project targets the top 10% highest cost, highest need individuals experiencing homelessness, and that is what gives this project its name. These individuals often have multiple comorbidities, as Kim mentioned, including mental health, substance use, chronic physical health conditions. They also tend to have high emergency department utilization rates, and they're less likely to access primary care, which when you combine that with their health concerns and the high level of need, you end up with a high cost group. So back in 2009, the Economic Roundtable in Los Angeles released a report entitled Where We Sleep, and this report stated that individuals experiencing homelessness and receiving general relief in Los Angeles cost the public system $2,897 per month on average, while their counterparts who are in supportive housing only cost the system $610 per month. So the findings in this report led them to develop a data-driven triage tool to help identify who might fall into that 10th decile, that top 10% highest cost, highest need group of individuals who are experiencing homelessness. And the tool is founded on 2 key ideas. The first being that the greatest risk to people experiencing homelessness is the continuing crises in their lives, especially those that result in encounters with hospitals or jails. And the second being that the most compelling basis for prioritizing this population for supportive housing, especially considering the limited supply, is the cost avoidance to the public sector when chronically homeless individuals are housed. And so the tool itself looks at demographics, interactions with the health system, and diagnosed health conditions to predict the likelihood that a person will fall into the 10th decile. And it was pretty timely, and in 2011, CSH created a network of Tencessl Project collaboratives, and these utilized the triage tool to identify those high-cost, high-need, homeless frequent users and link them to services that would stabilize their health and housing. And then a year later, CSH received a 5-year Federal Social Innovation Fund award that allowed this project to spread throughout the county. And so the Tencessl uses a highly collaborative service model, and it has an emphasis on housing first and harm reduction approaches. And as I mentioned before, these individuals are identified using the triage tool that the Economic Roundtable developed, and they're actually training hospital staff to identify potential participants and screening for eligibility. So they're looking for people who are experiencing homelessness and possibly have above average hospital use. So if an individual is screened and they are found to be part of this population, they're connected to a Tencessl case manager. And it's a pretty warm handoff. The case manager is ideally armed with the patient history, discharge instructions, and medication information right from the beginning. And the case manager provides participants intensive case management, which is a mix of care coordination, so things like enrolling clients in primary care and behavioral health homes, scheduling visits, accompanying them to visits if it's appropriate, as well as housing navigation, so helping to prepare applications for housing authorities, looking for housing, negotiating with landlords, and assisting with move-in and transition support. They use motivational interviewing, and this whole process is initiated by connecting the participant to temporary housing and enrolling them in Social Security and Medi-Cal, which is the state Medicaid program, if they're eligible for those. So the health centers involved in the Tencessl Project use a patient-centered medical home model to provide integrated primary and behavioral health care. And the health center's providers work closely with the case manager to best serve the client. And all participants are connected to a health center as their permanent medical home through this project. It is important to recognize that the case management doesn't just end when the individual is housed, but they do continue to receive support as needed, and this might look like daily living skills or financial management assistance. So the goals of the Tencessl Project were to improve housing stability and health, as well as to reduce the use of emergency services using this targeted intensive case management approach, and of course connecting the individual to appropriate health care and housing. So if we're looking at the outcomes of this program, I think we can say they were pretty successful to date. 51% of all screened participants were engaged in either the Tencessl Project or another project if it's more appropriate. The other 49% may have declined services. They may have been discharged before they were connected with a navigator. They may have been excluded due to barriers that could have prevented independent living, or the case managers may have just not been able to locate them. Almost everyone who remains engaged in the program does obtain permanent housing. 47% are housed within 6 months and 98% within 2 years. And individuals are connected to temporary housing while they're awaiting that placement. There's a pretty noticeable reduction in emergency room visits, which as part of this project were down 71%. Hospital admissions went down 80%, and inpatient days down, I apologize. Hospital admissions were down 84%, and inpatient days were down 80%. And that leads to something that's pretty key for a lot of funders, which is cost avoidance, and we'll look at that a little closer in just a minute. And of course, all of this ties in with the triple aim of improved quality of care, reduced costs, and improved health outcomes. And that's through this patient-centered model that has helped to stabilize the health of these participants. So before we talk about cost avoidance, we do have to acknowledge that there are some program costs. And in the first year, the overall cost per person is $19,800 on average. Just under a third of that is going towards rental subsidies, which are mostly Section 8 and Shelter Plus Care vouchers. Another third is dedicated to the intensive case management and housing navigation that I mentioned earlier. And there's some costs attributed to data and oversight of the program, temporary housing while they're awaiting placement, and some one-time costs like screening and outreach and move-in costs. In the second year, the cost per person drops to $14,550, and the main portion of this, again, is rental subsidies. Case management costs drop as the participant gains some stability in their health and their environment, and some of the costs carry over from the first year, including patient transportation and data and oversight. But don't let those costs scare you. The investment in housing and case management does show major cost avoidance and savings for the overall health system. And by targeting the highest cost, highest need individuals, the Tencessl Project was able to see hospital cost avoidance of over $54,000 per person per year. And when you take into account program costs, you still have a net cost avoidance of over $34,000 per person in the first year. And this is because of dramatic decreases in ER costs and inpatient costs, which are down 67% and 85% respectively. And those are directly related to the reduced utilization rates I mentioned earlier. So to summarize some of the key features of the Tencessl Project, I would say that these 5 components are what make it unique and successful. Through targeting individuals, they truly find those who need these services most, and that is what results in those impressive outcomes and cost savings. And the triage tool, of course, plays a major part of that process, and this instrument does help to remove bias and make sure that those individuals being served are actually part of that 10th decile. Community collaboration is essential, and each collaborative brings together homeless services, including housing, as well as hospitals and health centers, to address all of the individuals' needs. Supportive housing plays a huge role, and by connecting each participant with supportive housing and subsidizing their rent by either Section 8 or shelter plus care vouchers, that participant has a safe, clean place to get their health back on track. And last but not least, intensive case management, which is kind of the core of this initiative. Being able to provide that intensive support is essential to ensure that highly vulnerable individuals are able to receive health care and housing that will help to improve their quality of life. And so with that, I am happy to switch gears and give Jill Lubin a chance to share about the Tencessl Project from the health center perspective. So Jill, would you mind just giving a brief introduction of yourself and your role in this project?
Yes, hi, good morning. I'm Jill Lubin, and I'm in Los Angeles. I work with JWCH Institute, a private nonprofit healthcare organization, and we've been involved with the 10th Decile Project here in Los Angeles for the last 3 years, and also done a similar project, a pilot project with the National Healthcare for the Homeless Council of frequent users with our Los Angeles County hospital system.
And I think you already started talking about this, but maybe you could just elaborate more about how JWCH got involved in this Tencessl Project.
Sure. A little over 3 years ago, the Corporation for Supportive Housing here in Los Angeles and the California Hospital and Medical Center, who were already part of the Social Innovation Fund, Tencessl Project in LA, were looking to partner with a health center in the downtown Los Angeles area to work together and employ and oversee a community health navigator that would actually be based at the medical center in the emergency department. And so JWCH, being a private nonprofit health organization and sort of a mainstay in the Los Angeles Skid Row community, seemed like a natural partner to work with this collaborative. We've also had a long-time grant for Healthcare for the Homeless services and have been connected to the National Healthcare for the Homeless Council as well. Next slide. I think the need largely grew out of the California Hospital Medical Center wanting to have a focused individual to be placed in the emergency department to increase the number of referrals to the 10th Decile Project. They did have social workers, of course, in the ED. However, there wasn't a dedicated individual to work on the project. And also, I think Corporation for Supportive Housing was aware of the project that JWCH had been participating in Los Angeles County with LA County Hospital system as part of a 3-year pilot project, so it seemed like a natural partnering. Next. Also, there was an increased it was noticed that there was an increased use of frequent users at the emergency department that were cycling through, but there wasn't often a linkage to a primary care home or stable housing. And so this is where the community health navigator, working in tandem with the social workers in the department, were able to provide that focused time and attention on individuals that were coming in and were identified as frequent users. And with ongoing funds, we've since had 3 community health navigators in the position, and we just received a word last week of our award for 2016 to continue the project. Next.
That's great. Can you describe some of the individuals that JWCH serves as part of this project?
Sure. So I think we've already had a pretty good description of the 10th decile population, and so certainly this is a target population for the Social Innovation Fund. And we also are seeing the general homeless population, which can be defined as frequent users of the county and private hospital emergency department, and as mentioned previously, that are coming in with issues such as hypertension, uncontrolled hypertension or diabetes, COPD, that also are coming in with onset of untreated mental illness or substance use. And again, these things were all mentioned in the previous slides. Next. One distinction, I think, between the 10th decile population and the general homeless population is while they have frequent visits to the emergency department, they may not be admitted. And one of the challenges, which I'll speak about later, is because they may not be admitted and just be cycling through the ED, sometimes when the community health navigator meets with the individual in, let's say, a Wednesday afternoon and then wants to follow up with them Thursday morning, they might already be gone. The target population in the generalist homeless population also has frequent visits because they may have medication lost or stolen, and they don't have a linkage to a medical or mental health home. And so that's really a key component for the community health navigator to assist in establishing that connection to a medical home. Many of these individuals are chronically homeless for 4+ years. They may not have seen a doctor in over a year. They may have been incarcerated and often have little or no support system. And as with the 10th decile population, there often are other competing priorities such as housing, food, legal issues, accessing benefits that may become, at the top of the list before actually accessing health care. So we see a decreased compliance to health appointments, a lack of adherence to medications, and so that's where we often see a cycling of individuals at the ED. Next.
Great. So one of the key features of the 10th Decile Project is collaborating with other agencies. What were some of the key partners that you work with on the 10th Decile Project?
Well, as mentioned earlier, since the project was defined here in Los Angeles, we do work closely with the Corporation for Supportive Housing and have for the last several years, the Los Angeles office specifically. Our partner is the California Hospital and Medical Center, which is part of a larger hospital group called Dignity Health, and they're one of several hospitals in the main part of downtown Los Angeles that serves the vulnerable and indigent population in the area. Housing Works is our housing provider that provides intensive case management, and our community health navigator does provide that warm handoff to Housing Works, and they provide the intensive case management and linkage to transitional and permanent supportive housing. And one of the real sort of, I think, unique features of Housing Works is that they work with the patient or the client for life. So once an individual comes into their system, everything from doing an assessment to housing applications to intensive case management, and even when an individual may lose their housing for one reason or another or become rehospitalized, they continue working with that same individual really for life. And that's sort of a unique feature. I've never seen that in any of the other housing providers or permanent supportive housing folks that I've worked with. And then JWCH, the agency that I work for and proud to have been here for many years, is a federally qualified health center. We have a large clinic in the heart of Skid Row where we have comprehensive health services, and we work very diligently to connect people to a medical home so they can have that continuity of care, consistency of provider, and so we're constantly trying to ensure that that warm handoff both to the Housing Works folks as well as to our own clinic takes place. Next.
So when you're working so closely with other partners, there are bound to be some challenges. So I was wondering if you could explain some of the challenges you've experienced working with a hospital and how you've overcome some of those.
Well, I think that largely, with any project, and certainly at the onset, is really having buy-in from the administrators and the frontline staff. So from the top down and the bottom up, it's really important to make sure that all levels that are going to be participating in the project see the bigger picture. They know the goal of the project. They know who's accountable for what. And largely that's done through maintaining regular communication, quarterly or regular meetings as needed. I think a large challenge that we've had is access to certain hospital database or electronic health system information. With our current community health navigator, we've had some difficulty getting access to the hospital database. You know, part of it is, of course, they want to make sure that all individuals that come into the system are vetted, but specifically what's happening there right now is that they're in the process of migrating to a completely electronic health system, and we're hoping by the early spring that we will be able to have access and also start having some discussions how we may be able to have a shared database. And I think space is often a challenge, not only space just in regards to data management space and office space, but also having adequate space in the ED or emergency department to meet with individuals and have privacy and a space where individuals can interact. Often people are doubled or tripled up in a room or area while they're waiting to be, you know, triaged or seen. In terms of patient demographics and cost data, that's sort of related to the hospital database and accessing information. It's not impossible. It just requires significant lead time. In our project with the LA County Hospital, we were able to get baseline data, cost data, as well as cost data after the duration of the project. And similarly, as you saw in the slides previously shown, we do have cost data for our local project here. Approval of resources, largely around referral or resource guides, just making sure that we have the time and the appointed individuals to take a look at the materials and get them approved. And sometimes, again, I think with all of these challenges, I think they're all workable. It just takes time and communication and a lot of patience.
Definitely. So one of the other pieces of this is working with a housing provider. So what does the relationship between the health center and the housing provider look like?
Well, the relationship is largely between the community health navigator, who's based at the ED, and our partner Housing Works. There's regular phone and email, occasional meetings, and then we meet or try our best to meet quarterly as a collaborative. Also, the community health navigator has been invited to participate in a variety of trainings by the housing provider and other local providers in and around the area. There is that warm handoff when referring identified clients and follow-up to ensure that the that their progress is being maintained. There isn't really a direct relationship with the health center per se with the housing works folks unless there is a client that's a patient at our clinic, and then of course we will work directly with them to assist with follow-up appointments and transportation. But largely the relationship and the glue to the relationship with the housing provider is through the community health navigator.
Great. And then I just wanted to backtrack a little bit. And earlier you mentioned that JWCH had previously been a part of another frequent user project at the council. So I was wondering if you could describe the lessons you learned through that previous experience working with frequent users and how that played into the involvement in the Tencessl Project.
Sure. Well, I think that as I mentioned a few things before, but of course it's a large part is the communication piece and clarifying the roles of the partners at the onset of the project. And I think that Corporation for Supportive Housing did a very good job at doing so from the onset and really setting the tone and providing the coordination and facilitation of meetings with the California Hospital, JWCH, and Housing Works. And so I think developing that sense of camaraderie and collaboration through regular meetings, communication, accountability, that was definitely a lesson learned from the pilot project prior. In addition, I think building relationships and trust, and this is, of course, with our partners, but also with the clients, and realizing that individuals frequently using the ED, just like the folks that we work during outreach in the community, is that it takes time to develop that trust and that rapport. And it may not be at the first visit that the individual is going to engage in a conversation with the community health navigator. It may take multiple visits, and so while people are frequently using the ED and cycling through, it may be at a subsequent visit to the ED and seeing that same community health navigator and continuing the conversation, and at that point they may be ready to engage in services and receive referrals and linkages to the medical center or housing. I think also the follow-through, both the tracking of data and then following through on the linkages to our housing provider and to our medical clinic. One thing I did want to mention is that we were able to take a look at the individuals participating in the project and see if they were already consumers of JDBCH medical services, and because we have had an electronic health system for the past several years. And we were able to identify in our current project that about a third of the individuals that are being seen by the community health navigator at the hospital have been seen at a JDBCH clinic, largely our clinic in the downtown area. So they have already in the past had some sort of connection to the clinic, and now we're trying to find a way to reestablish that connection. And I think, of course, sharing resources so that we're not reinventing the wheel. And I think probably more than anything else that I've learned is patience, just taking the time, building the relationships, having significant lead time, and then doing the necessary follow-up to ensure that we reach our goals.
Well, great. Thank you so much, Jill. Really appreciate your input here. If anybody has questions about the Tencessl Project, please go ahead and submit them using the chat feature. I am excited to pass over the presentation to Amanda Pollock and Holly Garvey at Mercy Medical Center in Springfield, Massachusetts, to talk about their experience.
Hi, can you hear us?
Yes, we can.
Oh, great. Okay. So my name's Holly Garvey. I'm a nurse practitioner with Healthcare for the Homeless at Mercy Medical Center, and I have with me Amanda Pollock, who is a case manager. We refer to this program as the High-End Utilizer Program or Grant, and we affectionately call it the HUE Grant. I'd like to start with a quote from Eleanor Roosevelt. "One thing life has taught me, if you're interested, you never have to look for new interests. They come to you. When you are genuinely interested in one thing, it will always lead to something else." We have a genuine interest, obviously, in homeless health care. This led to our pursuit of a grant to deal with high-end utilizers in our community. In 2012, spurred on by the research of Dr. Jeffrey Brenner out of Camden, New Jersey, we applied for and received a 3-year grant from the Blue Cross Blue Shield Foundation to identify homeless patients who were overutilizing area ERs. Dr. Brenner was among the first to identify this group of super users who were receiving inefficient and high-cost health care. The goal was to connect patients to primary care by providing intensive, individualized case management. Our executive director, Doreen Fadis, had the opportunity to speak with Dr. Brenner at a conference, and she said, "How do we get this started?" And his advice to her was, start with only 2 people. So we did. We started with 2 case managers. And we identified super users. They were people who used the emergency room 4 or more times in the last 12 months. Then we did engagement with super users. We individualized care plans, and we collected data. And unique features of our program include intensive and highly focused case management. We looked at patients. We often had to speak to them several times on during the day on the phone about certain issues. Primary care connection. Fortunately, Healthcare for the Homeless provides primary care, so our case managers were able to bring patients right into the health center, and we were able to hook them up with services. We assist with obtaining insurance for patient and transportation. It's a multidisciplinary team. We have case management right on site, primary care, and we're also able to afford to provide patients with mental health services. And housing connection, we attend various service provider meetings in the community, and we look for housing opportunities for our patients. We have a high-end utilizer group with local EDs that we attend once a month. We were able to get additional grant funding and some patient services account from privately donated funds. We use that to buy bus tokens for patients, cab vouchers, beds, socks, whatever patients needed. If they were newly housed, we would purchase toasters or kitchen sets, whatever. There are multiple hospitals in this area that I've already talked about that were cooperating and doing the monthly meetings on the high-end utilizers. We also know that our clients have a tendency to jump from hospital to hospital. We've built the relationships with several area hospitals. We are fortunate to have a strong relationship with 5 area EDs and their social services departments. and they've helped us to collaborate discharge plans for our patients. In the initial stages of this program, we also had a connection with one of our local universities, UMass Amherst. We had a student intern working with us, and he collated data to assist us with evidence-based measurements.
We have 2 case managers. We accepted referrals from Healthcare for the Homeless, area ERs, and area homeless service providers. We also spent a lot of time at soup kitchens and shelters on the streets and getting to know the homeless population in our area and identifying potential clients through day-to-day conversations. As people got to know us, we had several self-referrals to the program. Due to the need for data gathering, we did have to verify that a person qualified and had the 4 or more ED visits in the past 12 months. And once we were able to do that, we were able to enroll them in the program. Once a person had been identified as a high-end utilizer, we would complete an initial assessment with the client and then begin building a client plan. Our approach is entirely patient-centered. At the initial appointment, we discuss with a patient that they are in charge of their decision-making, and we'll help support them in whatever those decisions are. So we get to know them as a human being, their personal narrative, and then we consistently show up. We're there for the patient. We're there with them through medical appointments, through social service appointments, whenever they need that extra support. We follow up and we follow through. If we are building a plan together and we work together to try to figure out how to make that plan possible. So maybe the patient will leave and go work on one part of the plan and we'll work on another part, and then we'll meet up and go from there. So we work on goal setting, so even what might be a small goal, all the way to big goals like housing, education, getting finances in order, small goals like following up on a phone call that was really hard to make. So we work towards small steps. We let the client lead. Like I said, it's patient-centered. And we have an equal client-staff relationship, but it's more at the client's pace. We find that having the clients direct the steps helps them make lasting positive change. So we use the 4 C's as basically an easy way for us to keep the focus of our work in our forefront. So we make sure it's client-centered. We have effective communication with our patients, with other area community providers. We have a strong community connections with area hospitals and service providers and other agencies. And we also know that we have to make sure we have a cost-benefit analysis so that we can keep moving forward with our program. The next 3 slides show patient stories. And we chose these 3 clients because they do have varying outcomes with their utilization. We did change the names just for your info. So Sam had 18 ED visits for the first 12 months prior to his enrollment in the program. During the first year of intervention, his ER visits jumped dramatically to 31 visits in a year. When we met Sam, he was not well. He was drinking daily. He was morbidly obese, depressed, sleeping out in the streets, had a debilitating skin condition. His family had stopped talking to him, and his only friends were his drinking buddies. Holly became his primary care. She met with him weekly to address his skin condition, and she referred him to the high-end utilizer program. I met with him the same day, and Sam was pretty resistant to case management, but I kept showing up to the soup kitchen to say hello and ask if he needed anything. If I heard he was in the hospital, I would show up. If I heard he was at Healthcare for the Homeless clinic, I would drop in to say hello. I consistently showed up. And through the Client Needs Funds, we were able to purchase clothing and shoes for him. I attended medical appointments with him, helped him set up a rep payee when he realized that money was a trigger for his alcoholism, referred him to local recovery programs, encouraged him as he made progress with his sobriety. I also referred him to an area rest home. He has just finished his second year in our program with intervention, and he's doing really great. He is living at the rest home. He is very involved with activities there. He's been sober for over 6 months, has lost 100 pounds, which he's very proud of. His skin has cleared up, and in his second year of intervention, his ER visits dropped to 0.
The other thing with Sam was he had come from another healthcare provider, healthcare for the homeless provider in another part of the state. So we were able to make that connection with that provider because when he came in, he was a very poor historian. So it turns out that he actually had an allergy to rubber, so we had to make sure that his shoes did not contain rubber, and that's why he was having this problem with exfoliation of his feet. So it was a nice collaboration with another healthcare for the homeless, and then moving forward with filling in the information and moving forward here.
Helga is another patient of ours. She was very resistant to case management and resistant to the high-end utilizer program at first. She had been homeless for 4 years, had several health problems, including a history of cancer. She was told about the program by Healthcare for the Homeless and by the high-end utilizer program staff multiple times, and every time she refused. And one day, about 3 months after she had been initially told about the program, she walked up to the high-end utilizer staff and asked her to re-explain the program. Helga enrolled the same day, and after a year in the program, her ER visits dropped by 45%. She and her husband have now moved out of shelter into their own home, and we were able to help her with furniture for her new home through donations.
One of the main things with Helga was her underlying mental health condition. She'd been seen by our psychiatrist, our licensed mental health counselor, and an advanced practice RN in psych. But she wasn't consistent, and she didn't consistently take her meds. But the nice thing about Healthcare for the Homeless was we were able, when she would come in to see me for medical, we would also bridge her scripts for mental health and try to get her back into seeing a mental health provider. We know that in our community, at least, it's very difficult to get into see community mental health providers. And if you miss a number of appointments, you often can't see someone for, another year. So that was a really important piece, the mental health integration within our program.
Jose was very open to case management. He's had 18 ER visits prior to enrollment in the program. A fun-loving guy who loves to tell stories, loves making people laugh. He's always laughing and joking. He has a daughter and 2 grandchildren he's very, very close with. But he has several health issues, and currently he has over 15 active medications. In the first year of intervention, Jose's ER visits reduced by 100%. He was doing excellent, making all his own medical appointments on time. He was, by all accounts, pretty stable. But in the second and third years, Jose has shown some recidivism of 4 and 5 visits, respectively. We're continuing to work with Jose. We continue to attend medical appointments with him, help make referrals to area service providers, and support with his general health and his housing and sobriety.
Okay, challenges and experiences. What's interesting, I think, so far has been we all have similar challenges and experiences despite what part of the country we're in or how big our programs are. Our client-to-staff ratio with the Blue Cross Blue Shield program was going to be, we're going to have 60 patients, so it was a 30-to-1 ratio. We realized at the onset of this that this was an impossibility, that the intensive case management was, how many times were you seeing someone or talking to someone in a day frequently?
Oh, sometimes you talk to somebody 3 or 4 times a day.
Right. So we decided that we could only manage a 20-to-1 ratio. So we ended up taking care of 40 clients. Some of them we intensively case management, and I think there was an ebb and flow of case management also. So we attended to, I think Amanda and her partner triaged people to see who really needed the most care at what time. We also have difficulty finding detox and recovery beds for our patients who are actively using. In this area, with our patients, we need to find a bed right now. If it's going to be, they're going to ask to call back every 2 hours, you're going to lose patients, and that frequently happens to us. Or on the weekends, what happens when we're struggling with trying to find a detox bed for someone on Friday. Then on Monday, we're trying to figure out where are they, what do they do for the weekend. Mm-hmm. We also have, many of our patients have sex offender histories, and this has been difficult to getting patients into recovery programs and housing, even rehab. Definitely in our area, there's a lack of affordable transportation, clients going back and forth to medical appointments, going to Social Security. So we often provide cab vouchers and bus tokens for our patients. We have a availability of some patient funds. We also do scheduling insurance-funded transportation. We have an RN who does that directly online with patients, trying to get them PT1 transportation. Another one of our challenges has been our lack of a database. I think other people have mentioned that also. We do all of our data compilation using paper charts. We use Excel to document our work. Hopefully, as our program continues, we will upgrade to a database. Our program is actually going to morph into some Mercy-based ER high-end utilizers, and we're hoping to utilize their database, and then we would be able to enter notes directly in the patient record. So there's no communication between the EMR that Healthcare for the Homeless has and the high-end utilizer grant. So it depended upon Amanda telling us what we needed to put into the EMR to identify that patients were using the high-end utilizer grant. Also with referrals and tracking that process, she would let us know who came in, and then, so the process wasn't effective, I would say. Some of the things that we realized, and I think other people have said this too, that we didn't from the start build in administration, the financial piece for administrative tasks. That was a shortcoming of our budget. We needed to factor in phones, laptops, software, supervisor time. We didn't realize the amount of time it would take for our case managers to get and make referrals, to collect medical records, and we realized we needed to get the data out, so we needed to get those records in. Some of our good experiences, we have the availability of a 340B pharmacy within our Healthcare for the Homeless program. We're able to get indigent scripts for patients, 14 days worth of meds. We have mental health integration right on site. Medical obviously is right on site, and we're also available to take questions from case managers via phone. We have a dedicated weekly staff meeting, and we address case management issues. All of the staff is included in that, so we can all talk about different resources. Case management, mental health, medical, high-end utilizer grant case managers are all at one meeting, and it becomes a nice problem-solving meeting. So going forward, obviously our 3-year grant cycle has come to an end. So the sustainability of the grant became very important. So we're looking at DISTI funds, which are Delivery System Transformation Initiative funds, and the high-end utilizer grant group is now working with our Mercy ER staff to identify Mercy ER super utilizers and then come up with individualized care plans to meet their needs and to reduce inappropriate use of our, and then we focus on our Mercy ER and hopefully improving health outcomes with the use of intensive case management. So back to the quote by Eleanor Roosevelt that the interest in one thing has led to something else. And now we'll turn it back over to Kim.
Thank you, Amanda. Can you pass the little ball back to me? That way I can advance the slides.
Yeah.
Thank you. So, Amanda and Holly, thanks for talking about the HUE program in Springfield. I'm going to say that the first question is for you guys because it came up during your call. We have one person asking how or if you coordinated with probation and parole for individuals who were involved with the criminal justice system.
Well, we work with AISS, that's the After Incarceration Service in the area, and one of our mental health, our licensed mental health counselor does get direct calls working with patients, getting them into mental health services. We also take on primary care patients, but as far as with the high-end utilizer grant intensively with POs, we haven't been.
No, if they told us that they needed support with that, then we would offer to, support them with their AISS services, but otherwise we weren't really involved with that, no.
But there are crossover patients that would definitely be working with mental health and with the high-end utilizer grant.
Okay, great, thank you. So going to go back to a couple questions for Lauren. First, they're kind of related. Do you find, and I'm not sure if we know this, but do you find that it was the same individuals year to year that have fallen into the 10th decile? And secondly, what prompts the assessment of an individual? How is the membership in the 10th decile determined?
I'd actually asked Jill about this because I wasn't sure if it was the same individuals that fall in the 10th decile year to year, and she had said that they weren't, they didn't have access to that data. Jill, correct me if I'm wrong. But as far as how an individual membership is determined, it is completely dependent on their responses to that triage tool. So you input the demographic information, interactions with the health system, current diagnoses, that type of information, and the algorithm will calculate the likelihood that they fall into that 10th decile, and it's kind of color-coded to let you know what that result will be. As far as assessment of an individual, I believe that is determined if somebody who is conducting the screenings or somebody on staff at the hospital identifies that an individual is experiencing homelessness and whether they believe they may have above average hospital utilization. I don't know if there are direct criteria for that, but I can certainly ask and find out and include that in the Q&A document. I don't know if Jill has a better answer for that.
Well, yeah, just wanted to add in terms of that, largely the social workers may be able to identify through the database or the electronic health system that they have, that an individual has had frequent visits to the emergency department and then can make a referral to the community health navigator to conduct the triage tool with those individuals. And of course, everything is self-reported by the individual when they're being assessed.
And this is Kim, just to add to that, I do know there's a significant amount of training that goes on for the social workers at the hospital to be able to identify those folks. Great, and so we are going to now move to the next question, which is around the cost studies for the Tencessl Project. And I'm going to go ahead and answer this one. The question is, are the data based on a pre- and post-study only? Yes, they are so far. If so, how do they account for regression to the mean? Prior studies have shown that when targeting very frequent users, the costs go down naturally over time, even without intervention. So it is unclear how much of the success observed to attribute to the intervention versus regression to the mean. Do they plan any studies with comparison groups to more accurately identify intervention effects? So the data that we quoted is from an evaluation of the program, in Los Angeles, and that is just pre and post. However, the Social Innovation Fund is part of a national demonstration project that includes similar, they're not exactly the same projects in San Francisco, Washtenaw County, Michigan, and Connecticut. And there is a national evaluation going on tying together those 4 programs. And every attempt is being made to get comparison groups to really, sort of test exactly the effects and others that the question addressed. So thank you for that. So any other questions we will respond to in the Q&A document that we issue after this webinar. So next steps are that today's recording and slide deck, as soon as they are available, will be sent to all attendees and registered folks who did not end up attending the slide deck and a link to the recording. We encourage you to sign up for our next webinar on December 10th, which will be engaging health and housing partnerships. We're excited to announce that this will be the first webinar discussing CSH's guide to creating health and housing partnerships that we will be releasing right around that time that has a bunch of tools talking about how health centers and supportive housing projects can come together to serve frequent users. And then finally, when you log out of today's event, when you close out of it, a browser window will pop up displaying a survey about this webinar. We need to report the results to HRSA, and we really value your input and use the input, use it all the time to create new content and to generate new ideas for our webinar series. So thank you very much for attending the webinar today. We look forward to having you on one in the future. Have a great day. Goodbye.